The lecture title, as you see it here, is the subject of a publication in the New England Journal of Medicine that was recorded and published in the fall. I was a panel member at the Consensus Conference and plan to give you an analysis of the paper. This publication changed several important criteria for diagnosing a failed pregnancy in the first trimester. The changes are due to some large multi-center studies that were conducted in the United Kingdom. Such studies have good and bad aspects from my perspective. I will discuss those points later. Although the conference was sponsored by the Society of Radiologists in Ultrasound, most representatives were obstetricians or emergency medicine physicians. 3 countries were represented, and all of the colleges sent non-voting representatives. There has been an explosion of information about the first trimester of pregnancy. Sensitive pregnancy tests now enable scientists to know that a woman is pregnant before she misses a menses. Chorion-Villus sampling has given us a window to chromosome anomalies in early pregnancy. Risk testing for chromosomal anomalies in early pregnancy has improved with the use of biochemical and nuchal translucency testing. Many lessons about early pregnancy have been learned through a variety of assisted reproductive technologies. Finally, we had the advent of high-resolution endovaginal sonography that has given us a view of the first trimester pregnancy that had never been dreamed of when I began my studies of diagnostic ultrasound. It is necessary to set the stage for some of the judgments of the consensus panel. We've learned by following women with mid-cycle pregnancy tests that the pregnancy rate is greater than we had previously thought. This can be detected by implantation. As soon as implantation occurs, within 2 days, sufficient HCG is produced to be detected chemically. This has been termed a chemical pregnancy. We have also learned by following these women that a reasonably large number of them lose the pregnancy on or about the time that they are anticipating a menses. So as far as they are concerned, they had an unusual menses, not an abortion. This has been termed a menstrual abortion. It appears that on pregnancy websites, however, chemical pregnancy is often used synonymously with a menstrual abortion. It isn't until a woman misses a menses, either goes to the drugstore or goes to her doctor and has a pregnancy test that is positive, that we have something that we can term a clinical pregnancy. We have learned that the loss rate of these early pregnancies is surprisingly higher than we had previously thought. Now, there is some disagreement about how frequent menstrual abortions are, but everyone concurs that there are a lot, ranging somewhere from between the high 20s and the low 40s when measured as a percent of lost pregnancies. We can see that at 4 weeks, we find the apogee of human pregnancy loss. At 11 weeks, human pregnancies are at the nadir of the loss rate. Thus, in 7 short weeks, we descend from the apogee to the nadir. It is in this turbulent time of pregnancy that we are focusing in this discussion. Now, some good news is that this high loss rate of early pregnancies is an entirely natural phenomenon. Most of these losses are secondary to chromosomal anomalies, not the chromosomal anomalies you typically think of, like Down syndrome or trisomy 18 or trisomy 13. We're talking about highly lethal chromosome anomalies that do not even allow a pregnancy to progress out of the first trimester. And a significant percentage of the ones that are not caused by chromosomal anomalies are caused by single gene lethal mutations. It is the sonographic identification of these pregnancy losses that is the subject under consideration. So once we have an established clinical pregnancy, we are far from over in terms of pregnancy loss. These pregnancies are termed spontaneous abortions, and those are the types of pregnancies we are trying to detect. We attempt to detect these pregnancy losses in women who are threatening to abort. Now, threatened abortion is a clinical syndrome. It is not a sonographic diagnosis. It is a syndrome that is comprised of early bleeding, mild cramping, and a closed cervical os. To be perfectly honest, I don't know a single gynecologist that actually checks the cervical os anymore. If a woman, their patient calls and says, "I'm bleeding," they want them to get a sonogram. They don't want them to come into the office for a physical examination. Now, when I was a medical student, we were taught that about 20% of women experienced threatened abortion. At the same time, we were told that the woman had about a 50-50 chance that she would have an ongoing pregnancy if she presented with this syndrome. Now, in fact, the term abortion shows up in a lot of phrases in clinical medicine, and many of these phrases are inappropriately used. An imminent abortion is an impending abortion in which bleeding is profuse and the cervix is softened and dilated. This type of patient should not get a sonogram, but as I said, occasionally they are sent for sonograms because a physical examination was not done. As it turns out, imminent abortion is a diagnosis that we can make. Here we see a sac that I'm sure you already agree is not a normal looking sac. We'll talk much more about that later in the lecture. You can see that the cervical canal is actually dilated by a blood clot, and the sonographer is nicely pressing on the anterior lip of the cervix, and you can see that it is softened. So this is a typical imminent abortion. An inevitable abortion is an abortion in progress. Again, this is a diagnosis that we can make from time to time. Here we see this poor little pregnancy being squeezed out through the cervix and will soon be lost. Probably the most misused term is missed abortion. You will frequently pick up a requisition that says, "Rule out missed abortion." Well, missed abortion is retention of a dead pregnancy for at least 2 months. Now, we may know that it is dead, but we have absolutely no way of knowing whether it's been dead for 2 months. So, in essence, there's absolutely no way that we can ever rule out a missed abortion other than by showing a live, ongoing pregnancy. As I've stated, threatened abortion is very common. In fact, it's probably the most common syndrome encountered in human pregnancies, as we said, occurring in approximately 20% of pregnant women, with approximately 60% going on to spontaneously abort. Now, this number, you will notice, is a bit higher than was classically stated 30 or 40 years ago. But the reason for that is well understood. Women are delaying the onset of pregnancy now, often into their late 20s, 30s, and even 40s. And with each passing year, the incidence of chromosomal anomalies rises. That is, all forms of chromosomal anomalies, including the very lethal ones that cause first trimester abortions. So with a higher average age of pregnancy, one would anticipate that the number of losses would increase.